Hey there, listeners. This is Gerardo.
This is Ellen Encisco.
We are research residents at Cincinnati Children's Hospital Medical Center, and we're super excited because the Intestinal Rehabilitation team at Cincinnati Children's is growing. We've gained a new attending surgeon, and to celebrate this, we're going to start a new series. We're kicking this series off today about intestinal rehab. What is it? What are the diagnoses? I know next to nothing about this. I don't know about you, Ellen.
Not enough.
This is the Stay Current Pediatric Surgery Podcast.
Hello, I'm Michael Helmrath.
That's Dr. Michael Helmrath. He's a pediatric surgeon at Cincinnati Children's Hospital Medical Center and the former director of the Intestinal Rehab Program at Cincinnati Children's. He's excited to bring in his friend.
I'm Paul Wales. I'm a pediatric surgeon.
And he led the Intestinal Rehab Program at the Hospital for Sick Children and is now joining Cincinnati Children's as the new and current director of the Intestinal Rehab Program.
Dr. Helmrath and we didn't work directly together for many years. I've obviously been aware of a lot of his groundbreaking work that he's performed in tissue regeneration.
A key part that Paul's team had come up with novel strategies, how you introduce new pharma to these patients. Many of the patients require a very patient-specific approach, which emphasizes understanding the natural history of the disease.
I guess, Ellen, the big question here is, why do we even need intestinal rehab? But to answer that question,
Dr. Wales brought up an initial question.
Well, let's go back one step before that and sort of define what is intestinal failure, because that sort of leads into who's going to benefit from an intestinal rehab program. And up until recently, there really was no standardized definition for intestinal failure.
It's really a functional problem.
Essentially, when someone's gut, for whatever the diagnosis, whatever the reason, their gut function is insufficient to absorb enough nutrients, fluids, calories to support survival, and in the case of children, growth, which is a big distinction between adults and children.
Now, these new guidelines, they say that for a patient to be defined as having intestinal failure, then they have to have inadequate intestinal function to the point where they necessitate parenteral support for at least 60 days.
And so earlier recognition and taking advantage of the biology of the gut that wants to accommodate, we call it adapt, and meet the needs of the child are time dependent.
So with the intestinal rehabilitation programs, we are taking care of patients with intestinal failure. And so what is intestinal rehabilitation?
So an intestinal rehabilitation program, as we defined also in these Aspen guidelines that just came out, is a multidisciplinary or interdisciplinary collaborative patient care paradigm that brings coordinated care for children with intestinal failure through comprehensive management of their specialized nutrition and other associated needs that they have.
It's like a dream team, but for pediatric guts. So on top of the nutrition, then you also have to think about the comorbidities, sepsis, liver disease, anything that would challenge the growth of this baby.
It's an amalgamation of experts that come from different aspects of care, providing a holistic, comprehensive, coordinated approach to patient management. Hopefully, by doing that, you streamline care, you improve communication, not only with the family, but also between care providers and team members.
What is intestinal rehabilitation really comes down to the key factors that drive that process, and that's nutrition in the gut. But it's also nutrition in the body, and it's healing.
People like Dr. Wales, Dr. Helmrath have taken care of patients with these issues before.
So it's pattern recognition, and that's what multiple eyes on a baby does, who've seen them over time.
It's pattern recognition, but then on top of that, it's understanding all of these different causes of intestinal failure. They were able to break that down for us.
Patients that are going to come to intestinal rehab program have intestinal failure, and we can divide the causes of intestinal failure into three categories. There's short bowel syndrome, which by far is the most common category in pediatric patients with intestinal failure. And causes of short bowel syndrome are usually related to diagnoses of or disorders of the neonate. So congenital anomalies such as intestinal atresia, malrotation, volvulus, gastroschisis, long segment Hirschsprung's disease, things like that, or acquired diseases of the newborn such as necrotizing enterocolitis.
Okay, so that makes sense. So basically, our first category for causes is any condition that may lead to the loss of intestines or impair the intestinal formation and therefore leave the bowel shortened. Will therefore cause the child to not be able to absorb nutrients as well, which we mentioned at the beginning is key.
Oh, and category number 2, that is motility disorders.
So if we think of the intestine like a pipe, and that pipe is made of muscle that contracts in a coordinated way to push food and stool from one end to the other, you can have abnormalities of the muscle itself or of the nerves that control that muscle. And the bowel is unable to push things through in a coordinated way.
So these children basically have difficulty passing the nutrients through their intestines as a result.
And they're therefore dependent on intravenous support.
Yeah, and then there's a third category.
What we call the mucosal enteropathies, or the congenital diarrheas. And these are conditions where the patient has all of their bowel, but the mucosa, the inside lining that absorbs, digests and absorbs, doesn't work.
And since we have these mucosal defects, they lead to hypersecretion and profuse fluid losses, such that, the bowel is unable to tolerate or absorb nutrients.
So 3 different flavors. First, you don't have enough bowel to absorb nutrients.
And second, motility issues. So the food's moving too slow, or in rare occasions, it's moving too fast. And then the third category of intestinal failure. So not only are the contents moving too fast, but this occurs due to the bowel's inability to digest in combination with increased secretions. And that's oftentimes congenital etiologies.
The reason it's important to at least identify these 3 categories is that some patients will have elements of 1, 2, or 3 of the categories the way they present.
For example, think about gastroschisis. The bowel could be short because it was not all viable. It could be inflamed, so it doesn't absorb well. And all of these issues might affect motility too.
So a kid with gastroschisis could essentially have all 3 categories.
Right.
So any patient that fits one of those 3 categories is going to be referred to intestinal rehab program. And although most of them are infants or babies, there are some older kids that develop.
Wait a minute. You see intestinal failure in older pediatric patients too?
Things like inflammatory bowel disease or Crohn's disease, where they've had, lost gut as a result of complications of that. Trauma, malignancy, vascular thrombosis that has led to gut loss. These are diagnoses that we tend to see more in older patients or in adult series, and less so in pediatrics.
Like we're going to get into the details of all of these things in later podcasts.
Yeah, those will be subcategories of this whole. That's why we're going to do a series. We're going to dive deep into each of these.
Certainly families that live within the region can get given the opportunities to understand delivery from the beginning is probably going to be beneficial for a lot of the patients.
The main reason that I think we're doing this podcast is because access and availability to an intestinal rehab program is still very, very rare.
There's really 3, time points where families reach to us.
Okay, so there's 3 different categories of intestinal failure. There are also 3 general time points that these diagnoses could be picked up.
And by picked up, we mean also and then referred to intestinal rehab centers.
The first one is a prenatal diagnosis.
Prenatally, when there's a prenatal diagnosis, that typically ends up being an atresia, could be with cystic fibrosis, gastroschisis, very commonly.
The second time point would be postnatally with acquired problems such as volvulus or neck.
The third one, which is patients who are discharged, they don't really progress outside of the hospital, and then they come back and then they have a later diagnosis that maybe leads to short gut or something other diagnosis that leads them to necessitating intestinal rehabilitation. So those are the 3 time points.
The fact that we have these different times and people present, we have to have an infrastructure to be able to have the families get the support they need when they need it.
Now you just brought in...
That's Todd Ponsky. He's a pediatric surgeon at Cincinnati Children's Hospital.
The two of you being the two world's experts all under one roof. Why did you do that?
So I've long believed that your ideas that first come to your head always have ways to improve, and that you only see things through one way. Innovation comes from multiple approaches to the problem and different visions of the problem. The more expertise you bring in, the better the outcome is.
So that combined knowledge of Dr. Helmrath and Dr. Wales, along with the experience that we have at Cincinnati Children's Hospital, is great because there are a lot of next level questions that honestly need some better answers.
How do you take the older child who's had intestinal failure and they're entering their late teen years and later? That's going to be a major obstacle that we need to address that is currently not being met. How do you integrate new strategies of therapy? How do you look at new therapies like drug therapies and say, not who can get it?
Previously, we didn't really have good, robust data to answer these questions.
So Cincinnati Children's is really uniquely situated in this endeavor now that these two surgeons are under the same roof.
But to have the team approach and the integrated approach for the complex patients, it's a rare thing to find, and we are going to expand it to a point that it's never been done before.
Phenomenal. All right, Rod.
Okay, so having the whole team of everyone necessary is key. Obviously, we have the surgeons, we have the GI doctors, but we also have the neonatologists, and probably more importantly, the part of the team that is not physicians.
But you can't say enough about the dietitians and understanding the nutritional needs of a child as they are met. Social work is really key. I think the other aspect is that our extended providers, the people that are at the bedside, our nurse practitioners are fantastic.
And the list just keeps going.
Some people would say pharmacy as well, and as well as social work. Really good interventional radiology, for instance, pathology, and all the other sort of ologies, like endocrinology, nephrology. With
improvements like transplant and multidisciplinary organizations, we can see some really big strides forward in this field.
The survival overall in big programs is usually over 90% long-term survival.
And while this is a cause for celebration on its own, keep in mind that it has also raised a lot of new issues.
But now what we're seeing is we have kids that have developed chronic comorbidities that we didn't really see to the same extent because they didn't live long enough.
Now Dr. Helmrath and Dr. Wales are seeing diseases like
renal dysfunction and metabolic bone disease, and then the neurocognitive issues and the quality of life issues. And that's why having a coordinated team that can track these problems long term is vital.
Okay, so if you're listening to this podcast and you're thinking to yourself, what am I going to get out of this series? How is it going to help me?
I think the big key to a person watching a podcast is that they get hope. These are wonderful children. There are opportunities to grow up and to live the lives that their families want is really in front of them.
You're going to hear some experts talk about their process for taking care of these patients, how they think about them, what important things to know when you encounter one of these patients, and may or may not need to refer them to a dedicated center.
And people can't believe the culture that happened in the NICU. My goodness, I saw no way forward. And look, there's this little child full of life, and there's nothing that puts more energy back into you wanting to go better than that hug. Like I said, we work for hug.
There you have it. Episode 1 of our series on intestinal rehab. If you like this or learned something, make sure to follow us on social media, subscribe to our YouTube channel, download the Stay Current Pediatric Surgery app, which is in the Apple App Store, the Google Play Store. But until then, I'm Rod.
And I'm Ellen.
And remember knowledge should be free. Yeah, there's a little lag there.
Should we do it again?
That's okay. I think it's better this way.